Good afternoon, guys. Today I will be discussing a very important branch, which is psychiatry. So I will be discussing psychiatry branch. This branch is very important in Plab 2, okay? Before I start talking about psychiatry and psychiatry structure, I'd like to tell you one thing. Whenever you have a station psychiatry in the exam, okay, you need to bear in mind two things that you will start your station with, two things that nobody will say, two things that nobody will pay attention to, but they are very important. What are the two factors or the 2 points that I would like to emphasize on whenever I approach a patient with psychiatric problem? Number one, the general look. The general look is basically when you open the cubicle, when you look at the patient, if a patient is depressed, you will see that this patient is basically not caring so much about himself or herself. This patient might not be wearing like nice clothes. This patient, for example, if he's alcoholic, if he's on drugs, maybe the patient will, if he's having or she's having withdrawal symptoms, is scratching the body. So the look, when you open the door and see the look of the patient, that's one thing that you must look and bear in mind, but don't tell the patient. Don't tell the patient, well, you look that you're not clean. You look like that you're not having nice clothes. You look like that you are not tidy. No, that's for you. Something that you can see, and they will give you a message that you will keep to yourself, number one. Okay? However, there are things that when you open the cubicle, you can acknowledge. If the patient is sitting irritable, okay? If the patient is sitting scratching, if the patient is sitting, these are all withdrawal symptoms of, for example, stopping some drugs like heroin, or someone who's alcoholic, and they can be like shaking their legs. So you can acknowledge this. I can see you are scratching your body. Can you please tell me, how do you feel? I can see that you are shaking your legs. Can you please tell me? So that's something you can acknowledge. So number one, the first factor is look at your patient and see how the patient is, and acknowledge if you can. Acknowledge if you can. That's number one. Number two factor is psychiatry is not about finishing the station. Psychiatry is about making the patient talk to you and open for you, and how you talk to the patient is not what will you do with the patient, it's how you talk to the patient. For example, you open the cubicle and you see a girl who is sitting looking down, and she looks very upset. So you have two factors here. The fact that she is looking down, you'll acknowledge, I can see you are looking down, I'm doctor whatever, I'm here to help you. And the fact that when you try to tell her, can you please tell me why you're feeling sad, she's not gonna open for you. If she doesn't open for you, you can basically put your voice down, your posture, everything, show her that, Alicia, I'm here to help you. Stop for a few seconds. Alicia, can you please tell me why you're feeling so sad? Stop. Alicia, can you open for me, please? I'm here to help you. Alicia, the final weapon is confidentiality. Everything that we will discuss here will be confidential within the team. So basically, the second factor is how you approach the patient who is depressed, who's upset, who doesn't want to talk. How you approach the patient, how you talk to the patient, your tone of voice. You're not going to say, well, Alicia, how can I help you today if Alicia is depressed? Well, Alicia, I can see her upset. Can you please tell me what's happening? No. It is the way you approach the patient, your tone of voice. Try to please be nice and kind. Okay. There is one thing. If the patient is coming to you and is saying, doctor, I want to quit the drugs, for example, or I want to quit heroin. I want to stop drinking alcohol. All the time. Acknowledge. All the time, tell the patient, that's very nice. It takes so much courage for you to come here. I will definitely help you with that. So please, acknowledging, please, opening, making the patient open. Please, the way you approach the patient, the way you talk to the patient is very important in psychiatry stations. Okay. So bear in mind that when you open the cubicle, you need to look at the patient, how the patient is. You need to acknowledge what's happening, the way, the tone of voice, on how you are talking to the patient, on how you're opening to the patient. And very important, another point that's very important is basically signposting. And when you ask the patient a question that sound quite odd, try to signpost or try to use a third person. For example, I'm trying to ask a patient about suicide. I'm trying to ask a patient, have you ever tried to harm yourself or harm others? I'm not going to say to the patient, have you ever tried to harm yourself or harm others? No, I'm not going to say that. I'm going to say, well, Andrew, whenever we have some patients who are upset or who have low mood, sometimes they tend to hurt themselves or hurt others. Have you ever experienced the same thing? So basically use a third person. Using a third person will make your job easy. Using a third person will make the patient feel good about himself or about herself. Using a third person, okay? Alicia, some people when they go through difficult time or some people when they go through tough time, they tend to see things or hear things or feel things that are not true. Have you ever experienced the same thing? Asking about hallucination. So basically, use a third person. Basically, psychiatry is about the way you talk to the patient, how you ask the patient, acknowledging what's happening, reflecting on what's happening, how you speak to the patient, tone of voice. All these things are very important in psychiatry station before I start psychiatry. And this is the first 30 seconds, the first 1 minute in the station, which will be the first impression. Now, let's talk about psychiatry structure. And I will give you the structure in psychiatry. Whenever you approach any psychiatric patient, the structure is MC famish. MC famish. Okay, this is the structure, MC famish. But bear in mind that I am not going to use all the structure in every single station. Every station will have specific questions. Every station will have potent questions. And that's it. So I'm not going to use everything in every station. No. So let me tell you what is MC famish. And let me tell you how to start the structure. Before we speak about MC famish, don't forget the first 10 minutes I've spoken to you about acknowledging, reflecting, look at the patient, how to make the patient open, then you will start asking the questions. M stand for mood. So M stand for mood. Mood. Whenever I ask the patient about the mood, simply as simple as how do you feel? How do you feel? How is your mood today? That's it. So Mr. Andrew, how do you feel? Mr. Andrew, how is your mood today? Some people use the scale, on a scale from 1 to 10, 1 is being the lowest mood, 10 is being very happy. How would you grade your mood? Which is not good way of, explaining or exploring about the mood. It's just how do you feel today? How are you feeling today? How is your mood today? C is for cognition. C is for cognition. C is for cognition. Cognition means concentration. In simple terms, cognition cognition means is the patient confused or not. So cognition is basically means is the patient confused or not. Watermelon, guys, yeah? Cognition. So whenever I approach a patient who is confused, I will ask these questions. 5 questions. 5 questions. So now we know how to ask about the mood? Yes. Now cognition. Don't worry, you're not going to be lost. Just follow the structure and then I will tell you how to use the structure. Cognition. I will ask 5 questions. What are the 5 questions I ask in cognition? Can you please confirm your full name? Can you please confirm your date of birth? Your date of birth. Third, do you know where you are? Do you know where you are. Okay? Where you are. Do you know who I am? Who I am. Do you know who brought you here? Do you know where you are? Do you know who brought you here? Who brought you here? And at the end, you can even ask one more question. Do you know where you live, or your address? Where you live. So, can you please confirm your full name? Can you please confirm your date of birth? Do you know where you are? Do you know who brought you here? Do you know who I am? Do you know where you live? Cognition questions. If the patient is answering this question good, the patient is not confused. If he's answering the questions not good, he's confused. F is for 4 things: family, friends, forensic. So F, family, asking about family. F is asking about friends. F is asking about forensic. So F is basically, I will consider it as support system. Support system. F is asking about the support system. Who do you live with? Who do you live with? F, consider it as support. F, who do you live with? Who do you live with? Do you have any support from your family? Do you have any close friends? Do you have any close friends? Do you have any close supportive friends? Forensic is, do you have any problems with the law? Do you have any troubles with the law? So F is forensic, which is problem with the law, to show if this patient, like, to give you an idea about the lifestyle. Okay, but it's mainly for support, friends and family. Okay, so always ask about the support system around the patient. So I will consider this as support. Support system. Okay, so family, neighbors, close friends. Okay, and how's the relationship between you and them? Are they supportive? Okay, now A is for allergy, and it can be for alcohol and the other drugs. So A is for allergy, and it can be for alcohol and the other drugs. Okay, A, allergy, and it can be for alcohol and the other drugs. So do you have an allergy to anything? Yes, no? And then alcohol and the other drugs. And the alcohol and the drugs, they have some questions which they are the same. Alcohol and drugs, they have questions that are the same. What do you mean are the same? For example, what are the alcohol questions and what are the drugs questions? Okay, so A, allergy, alcohol and the drugs. Okay, if the station is alcohol, if the station is drugs, talking about drugs, quitting drugs, what are the questions? Alcohol. So the questions, I split them into 2 groups, and they are both the same. 2 groups means, first I will ask about the alcohol. The second group is cage TWD. Drugs is the same. First I will ask about the drug. Second I will ask about TWD and cage. So again, A for allergy, alcohol and other drugs. What do you mean by alcohol and other drugs? I know how to ask about allergy. Alcohol and other drugs means if the case is talking about alcohol or drugs, how to ask. I said I will split the question into 2 groups. The alcohol itself, cage TWD. If the station is talking about drug itself, cage TWD. What is the alcohol itself? That means that if the station is talking about alcohol, so what do you drink? How much do you drink? Since how long have you been drinking? So what do you drink? How much do you drink? Since how long have you been drinking? So it's questions about the alcohol itself. What type of alcohol? How much does he drink? For how long he's been drinking? The cage TWD, cage C for cutting down, A for annoyed, G for guilty, A for eye opener, C for cutting down, which means have you tried to cut down? If the patient answered yes or no, that's cage, yeah? I started with cage. C for cutting down. Have you tried to cut down on drinking alcohol? If the patient said yes, I tried, always explore. Whenever the patient said yes, always explore. When did you try to cut down? What did you do? Did you seek any medical advice? Any challenges when you tried to cut down? Why, Dr. Mo, if the patient has, if I'm asking him about cutting down and he tried to cut down before, I need to explore? Because the challenges that he found during cutting down, you need to work on it, because this time he's coming with you to cut down. So the challenges that he had, you need to work on them so he doesn't have again. So C for cutting down. A, annoyed. So it means that you need to ask the patient, do you feel annoyed when people criticize your drinking habit? But it's better to ask it that way. Do people criticize your drinking habit? If the patient said yes, how do you feel about it? Doctor, I feel annoyed. Okay, this is one of the things that alcoholic patients do feel. If someone's criticizing their habit, they feel annoyed. For example, why do you smoke? Smoking is no good. Usually heavy smoker, they feel annoyed when people do this to them. This is the same. So have people tried, do people criticize you? Yes, doctor. How do you feel about it? That's the annoyed question. I feel annoyed, doctor. G is guilty. Do you feel guilty about your drinking habit? Do you feel guilty about your drinking habit? Is eye opener. Eye opener means that alcoholic patients, when they woke up in the morning, first thing they want to drink. So do you feel that you need a drink in the morning when you open your eye? Or once you wake up in the morning, first thing in the morning, do you feel that you need a drink? Then TWD. T is tolerance. W is withdrawal. D is dependence. T is tolerance, which means that patients who are alcoholic, when they drink, for example, they start with bottle, then it doesn't give them the same effect, so they need 2. Then later on they need 3, so the need is increasing to have the same effect. So that's tolerance. So I always ask this question. I will always say to them, well, Mr. Andrew, do you feel that you need to increase the amount of alcohol you drink in order to get the same effect? Yes, doctor. Withdrawal. Mr. Andrew, whenever you don't have alcohol, or whenever you don't have the drug, for example, whenever you don't have alcohol, how do you feel? Then he will give you the withdrawal symptoms, the symptoms that he has. Why do I need to ask about withdrawal symptoms? Because I will need, if a patient is coming to me and he wants to stop alcohol, I will need to give him medication, symptomatic treatment for the withdrawal symptom that he's having. This is data gathering. D, dependence. Dependence means that the patient cannot do his daily activity without drinking. So I will ask, if you don't have the alcohol that you need, or if you don't have the amount of alcohol that you usually have, do you feel that it's affecting your daily activity, or do you feel that it is making you struggle to do your daily activity? Yes or no? So basically these are the alcohol questions that I will ask if the station is talking about alcohol. What about drugs? It's the same. Drug and TWD cage. Drug. What drug do you have? But in drugs, I will need to ask a bit of more questions. So drugs, I said 2 types. I split the questions into 2 groups. The drug itself and then cage TWD. The drug itself. What drug do you have? How much? Since how long? How do you inject it? How do you take the drug? Sorry, not how do you inject it. How do you take the drug? Is it inhalation? Is it sniffing? Is it injection? So how do you take the drug? And whenever the patient tells you that he takes the drug injection, always the following question will be, do you share needles? If he said yes, always the following question will be, have you heard about needle exchange program? Have you been tested for, or have you done STI screening and HIV? So this is the extra questions that I will add if the question is about drugs and if the patient is taking an IV. So again, drugs questions, two groups. Drug itself, KHTWD. Drug itself, what do you take? How much? Since how long? How do you take it? How do you take it? If the patient said IV, I inject, you must ask, have you heard about needle exchange program? What is needle exchange program, guys? It's basically you go into the center, you give them your needle that you used, they give you a new one. That's needle exchange. Why? To avoid sharing needles, okay? So have you heard about needle exchange program? And then you can ask them about, have you been tested for, or when was the last time, or when, or have you been tested for STI and HIV? That's if it is drug, okay? Then KGTWD are the same questions. Cutting down, annoyed, guilt, eye opener. TWD, tolerance, withdrawal, dependence. It's the same but drug. Same way of asking. So that's for A. Alcohol, allergy, alcohol, other drugs. Then M. M is for medical conditions and medications. So M is for medical condition, mental condition, and medications. So M, medical conditions, mental conditions, medications. That's M, stand for. Medical condition, mental condition, medication. What about I? What about I? I is insight and the impact. So I is insight and impact. What do you mean, Dr. Mo, by insight and impact? Insight means if the patient has a problem and the patient knows that he or she has a problem, that means the patient is having or has an insight. He knows about his problem. So that's insight, which is good. But if the patient is suicidal and she doesn't know that she has a problem, that means that she doesn't have insight. So that will bring us to management, and then we will admit. So if the patient does not have insight to his problem, you must admit. If the patient does have insight, you don't admit. Basically, consider it as mental capacity. If the patient does not have insight, so that means that the patient does not have mental capacity. That means that you need to admit the patient insight. If the patient does have insight, that means that if the patient does know about his condition and everything, that means that most probably you're gonna admit the patient. Most probably. So how do I ask about insight? Simply by telling the patient, Mr. Andrew, do you think that you have a problem that needs to be sorted, or do you think that you need our help, or do you think that you have a condition that needs our intervention? Insight. What about impact? Impact is always asking the patient about the impact of his condition on his life, daily activity, the relationship between him and the others around him, his job if he's working. So, Mr. Andrew, can you please tell me how is this condition impacting or affecting on your life, on your daily activity, on the relationship between you and people around you? So that's impact. So insight and impact. So insight and impact is the effect. So impact is the effect of this problem on this patient life and daily activity and work. Insight is, does the patient know that he has a problem or not? Okay, so that's I for impact and insight. Then S is for suicide. S is for suicide. S is for suicide. S is for suicide. So suicide is basically if the patient is depressed and he's suicidal or she is suicidal, how to ask suicide questions. If that's one of the cases when you open the cubicle, the patient is sitting upset, looking down, and she has taken some tablets to end her life, for example, and now talk to her, address her concern. So that will bring us into the suicide questions. Suicide questions is asking about before, during, after. So suicide questions are, don't forget, before, during, after. Before, during, after. So that's the questions for suicide. What do you mean, Dr. Mo, before, during, after? During is during the problem. When she tried to, attempt this thing. Before is before, after is after. So how to ask? Say, for example, if the patient is taking tablets to end her life. So during is while she was taking the tablet. So During will be what tablet did you take? When did you take them? How much did you take? Did you take them with water or with alcohol? Because if it's with alcohol, it's more damage. Okay? Apart from these tablets, did you take any other tablets? Okay? Why did you take the tablets? These are the questions during. So during the act, you need to explore about the act. If she cut her wrist, when, how, what did you use to cut your wrist? During the act, how much blood did you lose? So during. Before is, before you did this, did you tell anyone? Did you write any suicidal notes? Did you inform anybody that you're gonna do this? Okay? So that's before. So before is the preparation. Did you plan it or not? So that's before. After is after you did this. How do you feel about it? How do you see your future? How do you see your life? Now you are alive. How do you feel about it? If I ask the patient and I say, now you are alive, how do you feel about it? And the patient said, I feel shit. I wish I could die. That means that you need to admit the patient. Okay? So after is talking about the future, after the act, how do you feel about it? Now you are alive, how do you feel? Do you think you would do this again? How do you see future? Well, I see bright future, doctor. I regret that I did this. Good. But if no, I see a bad future and I wish I could die and I will try to do this again. So admission. So this is after. So before, during, after is in suicidal questions. Okay? Then finally, hallucination. H is for hallucination. H is for hallucination. So hallucination question. Hallucination question. So what are the hallucination questions? Hallucination could be tactile, could be visual things that they see, auditory things that they hear, tactile things that they feel. So that's hallucination. So a patient could be hallucinating because they can see something, they can hear something, they can feel something. So always whenever it's talking about hallucination, I always use these questions of the hallucination questions, which are basically things that the patient feel, things that the patient see, things that the patient hear. So always use a third person. What do you mean, Dr. Mo, third person? So always say, whenever some patients are going through difficult time, they tend to hear or see or feel things that are not true. Do you experience the same thing? So always hallucination, 3 types: visual, tactile, auditory. And whenever you ask about it, always use a third person and always say, whenever people pass through difficult time, use a third person. So it's an odd question, so use a third person. Or you can even signpost it. I would like to ask you some question that may sound quite odd. Please bear with me, it's a part of my consultation. Whenever the patient feel or hear or see things, have you ever, whenever the patient to go through difficult time, they tend to feel or hear or see things that are not true? Have you experienced the same thing? Yes or no? That's it, hallucination. And when the patient is hallucinating or when the patient is suicidal, I always tend to ask them an extra question. If things go wrong, okay, do you have any plan of protecting yourself? Why do I ask this question? Because some patient will be carrying weapons. Some patient will say to you, yes, I will carry knife. Yes, I will carry scissor. Yes, I will carry pistol. So basically, it is an important question for the safety of others. So basically, always ask them about an emergency plan. If things go wrong, do you have an emergency plan or things that you will do to protect yourself? All right. So this is the history. This is the psychiatric history. Okay, Dr. Mo, how do I use this psychiatric history? Because guys, whenever I start doing station by station, I would like you to be aware on how to use it, okay? Okay, if the station is talking about suicide, so the scenario, you will start the scenario with opening the door and the patient is suicidal and the patient is looking down, not looking at you. So you will start by asking the suicidal question, which is before, during, after. But make sure that she opens, make sure that you talk nicely. If the station is hallucination, so you will start by asking hallucination questions. If the station is talking about alcohol, then you will start by asking the alcohol questions. If the station is talking about heroin, ask the heroin question. If the station is a patient who's depressed mood, okay? So whenever you have a station. How do I know, Dr. Mo? You will know. From the stem, you will know that it is a hallucination station. It is, if the station is psychosis, or hallucination, you will start with hallucination question. This is psychosis. But if the station is dementia, a patient who was brought to the hospital, he doesn't know where he's from, he doesn't know anything about himself, and he is basically like doesn't know what's happening. So start with cognition question. So basically, I will start with that group of questions that is specific to every station. And then I will follow my structure. What do you mean, Dr. Mo? If the station is suicide, so I will start with suicide first, and then I will ask about everything else. 1-2 question about hallucination, 1 or 2 question about impact and insight, 1 or 2 question about medical condition, okay, 1 question about mood, how do you feel, 1 question about cognition. For example, if the station is talking about hallucination, so I will start with hallucination question, and then I will ask some of each. So from every letter, I will take 1 or 2 questions. For example, in suicide, I'm not going to ask all suicide. I'm just going to ask some people, when they go through difficult time, they tend to hurt themselves or hurt others. Have you experienced the same thing? I will ask about the mood. How do you feel? Medical condition, medication quickly. You understand? So basically, whenever the station is specific to something, I will start with it, and then I will ask 1 of each. But don't forget that impact, insight, suicide, mood, support are important in every station. Support system, family, friends, important. So impact, insight, suicide, mood, support, important in every station. Impact, insight, mood, suicide, support, important in every station. Why? Because depending on the impact, I will manage. Depending on the insight, admit or not. Depending on the suicide, admit or not. Depending on the support system, I will manage, because I will use this support system later on management by offering support system to these patients. Okay? So I will take this off, or I will leave it, and then I will start by discussing our stations 1 by 1. All right? Okay, the first station is depression. A patient who presented to the clinic. It could be the GP clinic, and it could be psychiatry department. So be careful. If the patient is in a GP clinic, the management will be different if he's in psychiatry. If the patient is in GP, you will refer to psychiatry. If the patient is in psychiatry, you're not going to refer. You're going to manage in psychiatry, okay? So a patient who presented to the GP clinic, okay, and the patient is having concerns. When you talk to the patient, when you open the cubicle, she is low, she is not giving you eye contact, and she is not happy, she's sad. So this is a depression station. So this is the first scenario, depression. So you will see, as I told you, you will acknowledge, number 1, I can see you are looking down, then I can see you feeling low, okay, and then you will start asking about the mood, okay, because this is depression station, mood, okay. I said mood is for depression, cognition is for dementia, hallucination for psychosis. So I'm talking about the station, yeah, the station itself. Suicide for suicide, and that's it. Alcohol for alcohol station, drugs for drug station. So I will ask, how do you feel? The patient will say low mood. I will basically ask about the patient sleeping, how because sleeping is one of the things that's affected by depression. So I'll ask about sleeping. I will ask about mood. I will ask about the patient weight, because they lose weight. I will ask about their appetite. I will ask about their libido if they are sexually active. So these are questions that you must ask in any depression question whenever you open and the patient is depressed. Mood, sleeping, weight, appetite, libido, and it's a must. Plus one of each. Let's say I've covered the mood. This is the depression station. So in depression station, this is my main concern, mood. So now I'm discussing depression station. I will take these questions out, okay? Because I would like to focus on showing you how you approach the station. So now my first station is depression. This is my first station, depression. Okay? So I said to you, I will start my history by asking about the questions that related to mood, and I told you. So this is the first station. This is the mood station. After that, I will take one of each, but mainly support. Don't forget, because the patient will need support. Suicide, very important in this case. Hallucination, very important. Impact inside. Okay. Now, my history is done. The positive is there in mood, and that's it. Everything else will be negative. All right. However, this low mood patient, maybe he's got suicidal tendency. She needs to end her life. In that case, I will admit. Or in that case, if it's in psychiatry department, I will refer urgently to psychiatry. This patient might be hallucinating. So the main thing is these 5 questions. Now, if the station is in GP clinic, now I'm talking about management. History is done. History, mood questions, plus weight, insomnia, sleeping, appetite loss, libido loss. These are the depression questions. Plus one of each quickly. Okay? Mainly ask about suicide, impact inside. Now, when I come to management, how do I manage this case? Simply, if the case is in GP clinic and it is mild depression, what do you mean mild depression? No loss of function. The patient is able to do the daily activity. The patient is sleeping okay. No suicidal thoughts. How would I manage depression if there is no loss of function? The patient is functioning properly. The patient is going to work. No problem in his job. He goes to work. He's able to do the daily activity. It's a GP clinic. Always offer CBT. CBT, cognitive behavioral therapy, talking therapy. However, if the patient who is coming to depressed and the patient is not eating, not drinking, weight loss, not able to do the job, severely depression, no insight, suicidal, and unemployed because of this, and he's drinking alcohol a lot, smoking a lot, taking drugs because of this, in that I will say psychiatry referral, urgent psychiatry referral, urgent psychiatry referral, urgent psychiatry referral, and I will talk to my senior. So talk to senior and urgent psychiatry referral. All right. Now, as I told you, if the depression is mild, I will treat CBT, talking therapy, which is basically someone to talk to make you feel good about yourself. Okay. Now, I can even offer one-to-one counseling session. One-to-one counseling session can be done if the case is challenging. Okay. The talking therapy can be offered in terms of websites, apps, applications, downloading websites, taking advice, but I can even offer one-to-one. Okay, so one-to-one counseling session. Now, if the case is moderate depression or severe depression, then I give them medication, antidepressant medication, which is used for minimum of 6 months, and referral to rehabilitation. Referral. So I will, number 1, give them antidepressant medication for 6 months, and I can actually refer them to be for long-term follow-up with psychiatrists. Now, these are the things that I will do. If it's mild, CBT. And CBT can be done through downloading websites or through downloading an app, and you get advice through it. Or it can be one-to-one session if it's challenging. What if it's a moderate or severe depression? Then medications, antidepressant medication for minimum period of 6 months. Now, there are other advice that I can give to a depression patients. Number 1, make sure, keep a diary of your mood. Talk to friends, talk to relative, okay, which what we call it support system. These are other things, support system, talk to relative, talk to friends, okay. If they drink alcohol a lot and if they take drugs, again, I will advise them about it, okay. So this is for depression and for how to manage depression. And be careful because support system is very important. It could be start from friends and families and neighbors, and it could end by groups, support to groups, like what? Like a group called the Good Samaritan group. Good Samaritan group, Good Samaritan group. And every depressed patient, please try to safety net any depressed patient, try to safety net that patient by giving a helpline in case things go bad, because you need to safety net for suicide. So any patients, you will offer them a helpline. You don't need to give them a number, and you can say to them at any time you feel low and at any time you feel that you will try to harm yourself or harm others, please, I will give you some numbers to ring. They will offer you help. Okay, now the second case is suicide. So the first case is depression, and we know how to manage it. Mild, moderate, severe, how to manage it. And you know that mild CBT, severe you start with medication, antidepressant for 6 months. And you know that plus the support system in both ways. I will have to talk about support system, could be family, friends, support groups, and at the end I will safety net for suicide. Safety net for suicide. Okay, the second case is suicide. So the first case was talking about mood, depression. The second case, the main factor from this history will be suicide. So it's a case of suicide. It's a case of suicide. What is the case? 20 years old girl presented to the psychiatry department because she took some pills. Okay, and she got her rest. Why? Because she took OCPs, she took ACPs, overdose of OCPs to end up her pregnancy, because she got pregnant and her boyfriend was not happy about it. So she took OCP to end her pregnancy, and she got her rest because her boyfriend was not happy about the pregnancy. Talk to her at lesser consent. So now, this case, you are in the psychiatry department. Some doctors will say, doctor, you know, like I will take history and I will manage her medically for the pills that she took, overdose and the rest. I will tell you, don't worry. In PLAB 2, there is a purpose from every station. If they said to you, this 25 years old, she took OCP to end her pregnancy because she got pregnant, okay? And she wanted to end it because the boyfriend is not happy. This is the question, the stem. And she also got her rest, don't worry. That means if they tell you that she is in the psychiatry department, that means that she is medically stable, because they would not bring the station medically not well and psychiatry not well. No, that means that she is medically well and she's in the psychiatry now. Talk to her as a concern. So it's a psychiatry case. However, if they want it medical, they will tell you she took overdose, and talk to her and take blood levels and, you know, and manage. But here it is in the psychiatry department. So how do I know? From the stem, from the question. The question said it is in the psychiatry department. So what is the challenge in this case? When you open the cubicle, the girl is 25, sitting, looking down, not able to talk. She doesn't want to talk. She doesn't want to open. So please, nice tone of voice, acknowledge. I can see, that's what I said in the first 10 minutes. I can see you are looking down. I'm here to help you. Please talk to me. Then I will go to the fact that she doesn't want to open. I'm here to help you. Please talk to me, and this and that. And at the end, offer confidentiality. Everything will be confidential and everything. Then she will start opening to you. So what is your history? Start with suicide. Start with suicide, which is, what did you take? How many? I took OCP. How many? When did you take it? How did you take it? The questions for, as I told you, suicide is before, during, after. Before, during, after. So before, during, after. During is the act, the pill, and the cut rest. Explore it. What did you take? How much did you take? Did you take anything else? Water or alcohol? Everything. Before is, did you tell anyone about it? Did you write suicidal notes? Did you inform any of your friends? Did you write a post on social media about it? After, how do you feel now? How do you feel about it? How do you see your future? Do you think you would do this again? That's before, during, after. After asking this question for suicide, as I told you in my structure, I will start with suicide. Then I can take one each. One, how is your mood? I can ask her about the mood. Then F is very important. F is very important. F is very important. F is very important. I can ask about the support system. Family nearby, friends nearby, relative nearby, very important. Okay, because this support system, I will need it later in management. I will ask about allergy, in case I'll give her medication, any medical condition, quick question. Insight and the impact is very important. Insight and the impact is very important. So how has this incident affected your life? How this impact affected you? And insight is, do you think you have something that needs to manage? Do you think that you need our help? That's insight. And in this case, if she has insight, if she said, yes, I think I need help, that's good, because that means that she has insight. If she think, no, I don't need help, that's bad. That means she may need admission. So insight is very important, because you know if she will need admission or not. Then hallucination, which is basically, you know, sometimes I'll ask you an odd question, that sometimes if when people feel low, they tend, or when people feel not happy, they tend to see or hear or feel things that's not true. Do you experience the same thing? Okay, that's one question. After asking about suicide, now I will manage. And what is the management? I told you. According to the history, I will give you scenarios. If the patient has done one-off, this is the first time to do it, and she did not intend to hurt herself. She said, I was scaring my boyfriend. She's not gonna do this again. She has insight. Yes, she needs help. She feels stupid doing this. After talking to the senior, you will send her home. So I will send you home after talking to the senior. Okay? But you must give her CBT, token therapy, offer her token therapy again, and you must basically safety net her for suicide. And you must talk about the support system. Safety net here for suicide. If you feel low, if you feel that you need to hurt yourself, please contact. I will give you a helpline to ring right away. And always talk to your friends, always talk to your close friends, to your family member. So always talk about the support system. Okay? Okay. But this case will need gynecology referral, because she has taken pills, OCPs, plenty of OCPs, and she's pregnant. So she will need gynecology referral. Okay, and this girl will need psychiatry follow-up, so you will need to be followed up in our psychiatry department. So psychiatry department, she will need follow-up, and she will need gynecology referral for the pregnancy that she has, and she is medically stable, however you can say, well, and will also refer you to the poison center to make sure that things are okay because of the tablets, the pill that she took. Okay, there is another case, but this is not our topic. This is not psychiatry. There is another case of a patient, but he is in the A&E. So the stem said he is in the A&E, and he took overdose of paracetamol. This case, A&E, overdose of paracetamol, he is not medically managed. And because he's in the A&E, so it's a medicine case. It's not here. Okay? Now, I cannot change all these scenarios. So I can bring you a suicide scenario. Okay? 30 years old, male patient, took 20 tablets of paracetamol because he is gay, and his mom found out he is gay, and she was very upset, and she stopped talking to him, so he tried to end his life. So he took the pill, talked to him, and this is concerned. He is in the psychiatry department. So he is in the psychiatry. Yes, he's in the psychiatry, so it's a psychiatry case. No medicine, don't talk about medicine. So I will start with suicide again, before, during, after, then I will go to mood, then I'll go to support, family, then I'll go to allergy, then I'll go to insight and impact, then I'll go to hallucination, and then I will manage. Managing a suicidal case, I said to you, if the patient is regretting, he's not gonna do this again, he knows that he's got a good future, he regretted, he thinks he's stupid for doing this, no admission after talking to senior, but you will give him follow-up, token therapy sessions, maybe counseling one-to-one sessions, and you will safety net him for suicide. But if he doesn't have insight, he will do this again, he wanted to end his life, he's not happy that he's alive, then what are you going to do with this case? You will admit the patient. Okay. What if the patient doesn't need admission? In this case, he will be admitted under the Mental Health Act because they don't have capacity. If he wants to kill himself, that means he doesn't have capacity. Okay. Then the third case is psychosis. Okay? Psychosis. So psychosis, basically, it is talking about a patient who is hallucinating. So, 45 years old, Andrew Thompson was brought by the police to the hospital because he was found in the park wandering and walking around. He doesn't know his house. He doesn't know anything about his family, and he was brought wandering. And it's written in the question that he thinks that the police is chasing him. That's it. He thinks that the police is chasing him, and he was brought by the police, and all investigation, the police done all their investigation, and then there was no problem. He did not have any convictions. So that's a hallucination question. That's psychosis question. Again, when you open the cubicle, The problem is not with the question, the problem is not with the history, the problem is approaching the patient. When you talk to the patient, he's gonna be looking around, acknowledge, I can see you are looking around. He's gonna be scared, I can see you are scared. Acknowledge, reassure him, you are in a safe place, I am the doctor, I'm here to help you and everything. After you approach him with that way, acknowledging and everything, how would you start? How would you start? How would you start? You will start by asking him the hallucination questions. The hallucination question, but be careful. Before I ask about the hallucination question, okay, I will start by 5-6 questions that I said about cognition. That's it. So in the psychotic patient, the patient who is thinking that the police is against him and everyone is against him and the police is chasing him, please, it is a hallucination station. However, the only modification, I will start by cognition question. Do you know, can you please confirm your full name? Can you please confirm your date of birth? Do you know who I am? Do you know where you are? And do you know who brought you here? Cognition question. And after that, I will say to him, I can see from where that you've been brought by the police. Okay, and can we have a chat? Some question I would like to ask that may sound intrusive, and then ask a hallucination question. So please signpost hallucination. Please, before hallucination, signpost. Dr. Mo, what is the meaning of signpost? Always say, I would like to ask you some question that may sound quite odd. Please bear with me and then ask a hallucination question. So the case of psychosis, how would you approach it? How would you approach it? How would you approach it? You will approach it by cognition, then hallucination. Cognition, then hallucination. So this one and this one, hallucination and cognition. This is that specific for the case, but please signpost. After that, quick suicide, quickly insight, impact, quickly mood, quickly support, because you will need the support system. Okay? Okay, be careful, because management, how do I manage this psychosis patient? Okay, the patient is coming, acute psychosis. How do I manage? Be careful, because if the patient is psychotic and he's hallucinating, what could be the causes? The causes could be alcohol or drugs. That's two of the causes. So alcohol and drugs are causes. So make sure you ask in your history about alcohol and drugs. Alcohol and drugs, okay? Amphetamine can cause it. Cannabis can cause it. Cocaine can cause it, okay? Alcohol overdose can cause it, so please ask about. Some infection can cause it, like HIV, like syphilis, can cause the psychosis, can cause the confusion, okay? So stroke, so you can ask any medical conditions or have you had any stroke. So please, in the history, I will ask about cognition, hallucination, alcohol and drugs, medical condition. Why? Because alcohol can lead to psychosis or hallucination. He's hallucinating. Drugs can make the patient hallucinate. Mini stroke can make the patient hallucinate. So ask about medical condition like stroke or mini stroke. Okay. So when I ask these questions in history, now I need to manage. How do I manage a patient who is psychotic? First of all, do you send the patient to home? No, the patient is not going to go home. The patient will be kept in the hospital, 100% admission. Okay. This patient will be admitted, and he will need psychiatry referral. Okay, what else? Do I need to do any investigations? Yes. What are the investigations in psychosis? Think about it. I said it could be stroke or mini stroke as a cause, so CT scan. I said it could be alcohol or drugs. So urine test for drug level, okay? And the alcohol, so liver function test. And I said it could be infection, so full blood count, ESR active protein, and actually I said HIV and syphilis, so PCR for HIV and STI screening, okay? STI screening and serology for syphilis. So Dr. Mo, where did you get these investigations from? From the causes. I said in psychosis, I need to ask about alcohol as a cause, drugs, cannabis as a cause, syphilis and HIV as a cause, stroke as a cause. So Alcohol, so liver function test, clotting profile, it affects the liver. Drugs, urine test, canals, urine test. I said it could be infection, so full blood count, ESR, selective protein. I said it could be syphilis, HIV, so HIV, PCR, and serology for syphilis. So these are the investigation, and even chest X-ray can be one of the investigation to exclude confusion due to pneumonia. Okay. How to manage? I said psychotic patient will be admitted, will be kept in the hospital. They need psychiatry referral. They need to be referred to psychiatry, and we'll be giving them antipsychotic medication, olanzapine, and risperidone. Okay? Don't forget to talk about what? Support system. So we'll contact the GP because he doesn't know about his family. So we'll contact the GP and we'll try to get in touch with any of his family. Okay, because he will need family support. Okay, what is the diagnosis here? When I give provisional diagnosis, how do I give provisional diagnosis? Is it dementia? Is it acute psychosis? What is it? Is it delirium? Guys, delirium and dementia, the difference is delirium is acute confusion. Dementia is patients who are chronically, they have this problem for a while and now it's coming back. So dementia on and off. So on and off patient who forget things and don't know anything about themselves, dementia. However, delirium is acute form. So I will contact the GP and I will ask about the patient medical history in order to see is it a case of delirium or dementia. Guys, what is the difference? Dementia and delirium. Delirium is acute, dementia is chronic. Dementia is something that he has already. Delirium is acute thing, okay? Now, the next case is drug and alcohol dependence. Okay? All right. Okay, drug and alcohol dependence. Okay, so in this case, drug and alcohol. So number 4 is drug, number 5 alcohol, or 5 alcohol and 4 drug, whatever. Alcohol and drug. Alcohol and drug are two cases. In both cases, you want to talk to the patient about the habit and manage. Okay, so the presentation is in the alcohol and drug is patients who self-presented, they came to the GP clinic because they want to quit the drug or they want to quit the alcohol. Talk to them, address their concern. So these two cases, 4 and 5, alcohol and drug. So it's a patient, 25 years old, 30 years old, 40 years old, who has alcohol problem, presented to the clinic, GP clinic, because he wants to quit, he wants to stop drinking. The second case, drug, a patient who is 25 years old, he's got drug problem, he is on heroin and he wants to stop the drug. So 2 cases, okay? So how do I address them? What is the history? In alcohol, alcohol history. In drug, drug history. But be careful, again, it's all about the start. It's all about the approach. Helena, Sobhi, can you please get me a cup with some ice, if you don't mind? Sorry? All right, okay. There is no ice? No. Okay. Can you take this monster and put it in the freezer, please? So, alcohol and drugs, cases of patients presented to the GP because they want to stop the drug or to stop the alcohol. I told you in psychiatry, it's all about the start. So basically, if you open the cubicle and these patients having any withdrawal symptoms like scratching, itching, shaking the leg, acknowledge. I can see you are shaking your leg, I can see you scratching, I can see you doing this, I can see you doing that, acknowledge. After that, you can praise them. Thanks for coming to see us today. It needs a brave person to come and start thinking about quitting the drug or quitting the alcohol. So praise, so acknowledge, praise, okay, in both stations. That's the approach. Then, in alcohol station, what is my history? Alcohol, A. You remember A? Alcohol? So I will start with the alcohol questions. And I said to you, alcohol questions are 2 parts. What do you mean, Dr. Mo? 2 parts talking about the alcohol itself. And the second part is CAGE, TWD. I've spoken about them. So I'll start asking about the alcohol itself. Okay, which is, what do you drink? how much do you drink, what type of alcohol do you drink, for how long have you been drinking, and cage TWD, cage, cutting down. Have you tried to cut down? If the patient said yes, always ask, can you walk me through it? When did it happen? How did it happen? Was it through medical advice? What are the challenges? Very important. What are the challenges when you wanted to quit the alcohol, stop alcohol? What were the challenges? That's alcohol. Then cage, CAGE, annoyed. When people criticize, do people criticize your drinking habit? Yes. How do you feel about it? G, guilty. Do you feel guilty? E is eye opener. Do you feel that you want to drink early in the morning? Then TWD, tolerance, withdrawal, and dependence. Tolerance, which means do you feel that you need to increase the amount of alcohol in order to get the same effect? Withdrawal, when you stop drinking, how do you feel? Because that is important in management, because what he's feeling when he stops alcohol, the symptom that he's having, you will need to give him medication for it. And at the end is TWD, D is dependence, which means that are you able to do daily activity when you stop drinking, okay? So now come to management. So after asking about the alcohol questions, I can ask about mood, yeah, one question. I can ask about support, yes, very important, support everywhere. Support everywhere, I can ask about support, yes, medical condition quickly. Impact and insight, important, okay, insight, do you think you have a problem that needs to be solved? Yes, okay, and impact, how is it affecting? Very important, impact. How is the alcohol problem affecting your life, your relationship with your people around you, your job? And then suicide, have you ever tried to hurt yourself? And then hallucination, a question each. But alcohol in detail, so alcohol in details and a question each, okay? Then management, so alcohol dependence management, how do I manage? So number one, this patient, I will offer him admission for rehab. So I will offer him admission for rehab. Admission for rehab, okay? Where is the admission? In the community, okay? Admission for rehab, okay? Or he can have alcohol community service. So he can be, if he does not want to be admission for rehab, alcohol community service. But I will talk about admission for rehab, okay? Talk to senior. I will do some blood investigations because it's alcohol affecting the liver. So full blood count, liver function test, urea electrolyte, kidney function test, okay? And basically ultrasound endoscopy if needed because it's liver, ultrasound endoscopy. Symptomatic treatment, step 4, symptomatic treatment. So step 1, admission for rehab, step 2, senior, step 3, investigation, step 4, symptomatic treatment, which is basically the withdrawal. So I will manage the withdrawal symptoms, I will manage the craving, okay, and the withdrawal symptoms. So symptomatic treatment, you remember the question that I said to him, how do you feel when you stop drinking or when you stop the drug? Yeah, whichever symptoms he gave, I need to manage. So if he said I'm vomiting, I start vomiting, I'll give him metoclopramide. If he said I start having diarrhea, I will give him loperamide. If he said I start itching, I will give him antihistamine. If he said I start being agitated, I will give him chlordiazepoxide. So basically, I will give this patient metoclopramide for vomiting, loperamide for diarrhea, okay? I will give him chlordiazepoxide for agitation. I will give him antihistamine for itching. That's for the withdrawal symptoms. This patient will need anti-craving medications, deterrent medication. Deterrent, D, start with D, so disulfiram. Anti-craving start with A, acambrosate. So anti-craving, anti start with A. Anti-craving, AC, acambrosate. Deterrent, D, start with D, disulfiram. So these are the medication that a specialist will give, okay, in such case. Don't forget that we always talk about support system, family, friends, relative nearby, and we always talk about CBT, token therapy. So support system is very important. Support system can start with the friends and the family and people nearby and relative, and they can end by CBT, token therapy, family therapy, okay? Now, if the patient doesn't work, you can tell him that there is Citizen Advice Bureau. Citizen Advice Bureau. Citizen means citizen. Advice means advice. Bureau means office. Office to advise citizens. So where they can help you. Okay. Always safety net for suicide, and always over follow up for the liver test. Okay. And always safety net whenever you have any thoughts of going back to alcohol, please contact us and we can help you with that, or we're gonna give you some numbers. Okay, then I will talk about drug. Again, it's a patient, 25 years old. He was taking heroin, and yes, don't forget an alcohol station as well. Ask about the stressors. Why some patients they drink a lot because they are stressed. So make sure to see if there's anything stressing this patient in his life or in her life, because you need to address the stress, because that's the risk factor. So stressors. Drug dependence, it's a case, 30 years old. He is on heroin and he wants to quit the drug, and he's coming to you and talk to him and this is concern. Heroin, okay? Simply, my history is A for alcohol or A for drugs? A for drug. Yeah, you remember the drug question? Again, the drug itself, KH, TWD. That's it. So I will start with A. And the alcohol again with A. A, what do you mean by A? A is this A here in the structure, which is alcohol and other drugs. So I will start by asking the question about the drug itself and KH, TWD. I have told you the questions, I don't need to repeat them. The drug itself, I said to you, what drug do you take, how much, for how long, how do you take it is very important. The patient will say, I take it injection. Do you share needles? If he said yes, talk about needle exchange program and ask about STI test or STI screening, and ask about if he was tested, if he had STI screening recently. So very important, okay? After that, KH, TWD, same, I will ask them. After asking this, one question each. Mood, one question. Support is very important. Family, and you remember from alcohol station, support system is a must. So ask about the support, people around him, or around him, medical condition, medication, eye impact inside, and the impact is very important. So you will use it in management. How is it affecting your life? How did this have it affected your daily activity? People around you, do you work? How is it affecting your job? Okay, insight and suicide and hallucination, one question each. Management, similar to drug, similar to alcohol. Offer rehabilitation, admission for rehabilitation. Senior, investigations. What are the investigations? As I told you, if you remember the question in the drug, when I said I will ask about STI and HIV because it's needle injection. So in the investigations, I will talk about full blood count, blood sugar, liver function, kidney function, urea electrolyte, but very important in the drug, HIV, Hep B, very important urine test. So HIV, Hep B, urine test, okay? Urine test drug level, HIV, Hep B because of that IV, the needle. So HIV, Hep B, urine test, okay? Very important. Okay, don't forget that this patient, you need to ask sexual history as well, because patients who share needles can have infection in the blood. Infection in the blood can be transferred through sex. So ask about sexual history as well. Sexual history. Okay. Management, yeah, we said admit, senior, investigations. We said don't forget the HIV and Hep B and STI screening. Okay. And as I told you, step 1, step 2, senior, step 3, investigation, step 4 is symptomatic treatment. Symptomatic treatment, which is exactly the same as alcohol. If the patient is vomiting, I will give the patient metoclopramide. If the patient is having diarrhea, lopramide. If the patient is having itchiness, I'll give him antihistamine. That's symptomatic. And then specialist drug. You remember in alcohol, the specialist drug, which means drug specified to alcohol. I told you anti-craving, AC, acomprazole, deterrent, disfuram. Here is the same. I will give a specific medication for drug withdrawal, which is methadone. What is methadone? It is basically a drug that we will give as a replacement medication. So it's a medication that exactly do the same effect as the heroin, but it's a medication, okay? So methadone. And don't forget that he will need follow-up. Don't forget the support system. Support system, you will say family, friends around you. So support system start with family and friends. Whenever you feel the urge to take the drug, talk to family, talk to friends, take their support, and CBT, talking therapy. So support system is very important, okay? And finally, safety net for suicide. Safety net for suicide and safety net for safe sex. Okay. The next case is acute confusion. Acute confusion. Acute confusion. In this case, the acute confusion is different from the psychosis. The psychosis, when the patient is psychotic, is hallucinating. Don't forget that in the provisional diagnosis, in a case of psychosis, you will say to the patient that you have a condition that's affecting the chemicals in the brain and making you feel, hear, see things that are not true, psychosis. But confusion, acute confusion, could be, as I told you, I'm sorry, there is something that we have said, that when I said acute confusion is delirium, chronic confusion is dementia, it meant to be said in this station. So in psychotic station, in the psychosis station 3, okay, you're gonna explain it to the patient as it is imbalance in the chemicals of the brain. That's why you see or hear or feel things that are not true, okay? This case is acute confusion. This case is acute confusion, okay? So the acute confusion case, in this case, the patient will come to you and they will say that this patient, okay, came and he is confused. He doesn't know anything. He doesn't know where he's from. He doesn't know anything. He was found here and there, okay? So be careful because psychosis and confusion are quite close. How to differentiate between them? Psychosis, the patient is hallucinating. Confusion, no hallucination, he just lost. He lost his memory. So how to differentiate in the stem or from talking to the patient between psychosis and hallucination? Because if you remember, in psychosis, I said you will ask cognition and hallucination. And in confusion, acute confusion, you will ask about cognition. Okay? So Dr. Mo, in this case, I will start with cognition. In psychosis, I will start with cognition. But how do I differentiate between 3 and 6? Again, psychosis, the patient will be imagining things. Imagining the police is chasing him. As I told you, remember? The police is chasing him. The police is after him. He committed a crime. His wife wants to kill him. His son wants to kill him. Psychosis. And the explanation is chemicals in the brain. Confusion, no. The patient will come to you. He doesn't know anything about himself. Name, no. Age, no. Where do you live? No. Anything? No. No. Confusion. Okay. In psychosis, I will start with cognition and hallucination. And I will take normal history, as you know. But because the patient here is confused, can you take history from a confused patient? Can you ask a confused patient any medical condition? The patient doesn't know even his name. So in this case, they will tell you. The question will say, let me read the question to you. 85 years old, was found. He doesn't know anything about himself. Okay, and he doesn't know his house. He doesn't know where he lives. Talk to him and do the many mental state examination and address his concern. So this is the question, okay? So this question is not history taking. It is many mental state examination. So again, this question is not history taking. It is a many mental state examination. So how do I manage the station? I will start by asking cognition. That's it. Anything else, Dr. Mo? No. Why no? Because you cannot take history from him. Then I will do the many mental state examination. Then I will manage. That's it. So again, the case will be ask the cognition question only, nothing else, because the patient is confused. What are the cognition questions? We've said them before. Can you please confirm your full name? Can you please confirm your date of birth? Do you know where you are? Do you know who brought you here? Do you know who I am? Do you know your address? He will not answer them. Then I will say to him, I will do some test, okay, to check how good your memory or how well your memory, okay? And please bear with me. And then you will start many mental state examination. Then you will manage, okay? So simply, this is the station. So history, cognition questions, I will ask. Then many mental state examination, okay? Then management. Okay, I don't need to talk about history because it's just 60 questions. Many mental state examination It is basically an examination where you will check the patient's memory, okay? It's a very simple and very easy examination, okay? And you need to memorize. You need to memorize, all right? So I will explain it, okay, at the end of the psychiatry, all right? Then you will go to management. Management of acute confusion is simply, first of all, at 6-minute bell, they will say to you, talk to examiner, in this case. So in the case of acute confusion, after the cognition and after the many mental state, they will tell you, talk to examiner. That's what you will be told, talk to examiner. How do I present this case to the examiner? So I will tell my examiner, for example, the patient scored in mini mental 9 out of 30, because mini mental state examination, it's out of 30. Dr. Amo, how do I do the mini mental state examination? How do I do it? I will explain it in a separate video, mini mental state examination, okay? So after you do the mini mental state examination, okay, in the case number 6, okay, after you do it, it is out of 30. For example, if you get 9, if you get 9 out of 30, okay, so that means it's severe cognitive impairment. So at 6-minute bell, because the station is 8 minutes, they will tell you at 6-minute bell, discuss management with the examiner. So in this case, you don't even discuss management with the patient because the patient is confused. So how would you do it? So you will say, well, my patient, I've asked my, that's how you talk to the examiners, that you, I'm suspecting, according to the history I've taken from my patient, I've asked him the cognitive questions and he's not able to communicate with me. I also performed the many mental state examination and my patient scored 9 out of 30, which means that my patient has severe cognitive impairment. So from that, I'm suspecting that my patient either has delirium, which is acute confusion, or what? Or my patient is having dementia, which is chronic. So either acute confusion or which is delirium or chronic. So I will contact the GP, I will contact his relative, and I will do some information. I will gather more details and I will see, has he had this before or not? Depending on what I'm going to get from them, it could be delirium or dementia. And what are the investigations that you will do in this patient? Again, like the hallucination. The patient who is hallucinating psychosis, it is the same if the patient is confused. So confusion, go back to confusion. What are the most common causes of confusion? Chest infection and urine, UTI. So you will do chest infection for this patient. You will do chest X-ray and you will do urine infection because you're suspecting UTI. You will do CT scan and all blood for infection markers. So this is what will be done for this patient. So this patient will have chest X-ray to exclude the chest infection, urine culture to exclude UTI, plus CT scan to exclude any stroke or mini stroke, and normal blood, which basically the causes for confusion. So in management, okay, the patient will be admitted and nothing else. Okay, next case is bullying at work. So remind me that you will need the many mental state examination by the end of the video. Okay, many mental state examination, how to do it. Don't forget that there is no history, only cognition. Don't forget that management at 6-minute bell. We'll discuss management with examiner, and that's how you're gonna say it. The same way I said to you, you will say he scored 9 out of 30, severe cognitive impairment, and then you will move on to talking about what you're gonna do to the patient, investigation, chest, urine, CT, blood. Okay, bullying at workplace. This is a case about a female who is getting bullied at workplace. So presentation, a patient with physical symptom of anxiety. She's anxious. When you open the door again, it's all about acknowledgement. It's all about looking at the patient, see how she feels, how she looks. So the patient will be anxious, acknowledge, give her confidentiality to open, make her open, then she will tell you that she's anxious and that's affecting her physical giving her physical symptoms. The patient is having heart racing when she's going to work. The patient is having panic attacks. I feel heart racing. I feel I'm sweating when I'm going to work. So physical symptoms. Okay, she's having low mood. Ask about low mood. Okay, this is the station. So the station is about female, anxious, having heart racing, having chest pain, shortness of breath whenever she goes to work. These are the positive findings. Ask about the mood. Ask about the support system. Ask about any medical conditions at all. Ask about suicide, and that's it. You don't need hallucination and you don't need insight. You can ask about the impact, how is it affecting your life and your daily activity. Okay, that's it. This is the case. It's bullying at work. A female who's getting bullied at work. Okay, these are the positive, and that's a history. Management, talk to senior. Symptomatic treatment, which will be basically relieving the stress by exercise, by yoga, by breathing exercise. You will ask her, have you spoken to the manager? Have you discussed this with the manager or the supervisor or the HR? So make sure you speak to her about this. Sick note, if she cannot go to work, you can give her sick note if she cannot go to work. Because she's having a panic attack, heart racing, and all of this, and anxiety, you can give her beta blocker. And don't forget specialist referral to psychiatrist. Why? Psychiatrist will give her talking therapy. Psychiatrist can offer her counseling sessions, Psychiatrist can offer her medications. Okay? Safety netting for suicide. All right? Okay, now the next case is gender dysphoria. Okay? It is 16 years old, presented to the GP clinic, and he is worried. Again, it's all about acknowledging. This male, he is having, when you talk to him, his problem that he's having feelings toward females. Sorry, he's having feelings toward the males, okay? So he's having feelings toward someone who is from the same gender. He is worried about it. He is feeling that he will be bullied. He is feeling that his family will think it's odd. He is very scared about it. So it's a counseling, pure counseling, no medicine in it. But in this station, make sure, Dr. Mo, number one, open the door, acknowledge. He will be worried, he will be anxious, he will be worried, acknowledge. Number two, make him comfortable, low tone of voice. Make him open. I'm here to help you. Open for me. I'm here to make sure you are okay. I'm here to help you. If he's not opening, confidentiality. That's it. The patient started talking. Then he will tell you, I am worried. Why? He will tell you, because I have feelings toward my friend. So always explore. What kind of feelings? Don't assume. Don't think it is sexual feeling. No. What kind of feelings? Since when have you been having it? So presenting complaint is feelings. He will tell you strange feeling. So the purpose of the station is reassurance. The purpose of the station is making him feel that it's normal, it's fine if you have feelings toward your friend who's a male. Nothing wrong with it. Why do you think there's something wrong? And explore why is he worried and try to work on his worries. So, what kind of feelings? Since when? How did it start? Why do you think it's strange? Nothing strange about it. It's normal to have such feeling toward the male. Nobody can choose what he feels inside and what he feels toward the others. It's something normal. Reassure, okay? And then when you reassure, when you explore the presenting complaint, always ask about the mood, always ask about the support, which means family, friends, siblings. Have you spoken to them? Have you spoken to your friend about it? Have you spoken to them? Why you are worried? Do you think, have they ever made any comments? If he said, I'm worried about my family, have they ever made any comments about this? Why do you think they will be, upset? Has anybody bullied you about it? Have you spoken to anybody about it? Always people around him, okay? Has anybody put a comment about this that's making you scared or worried? So always, and then ask about the mood, ask about the impact. How is this stress affecting your life, your daily activity, your relationship with others? Okay, ask about suicide. Maybe he's having suicidal thoughts. Okay, management Management. I've got two scenarios. If he has not presented anywhere, and if he's coming to you, first time coming to you with this, okay, so make sure he will need immediate support. And when I say immediate support, it's counseling stations. Support to start with, friends, relative, close people around him, sibling. So always your management, it is counseling. So it is about talking. So always your management will be start with support. If he's coming for the first time. So if he's coming for the first time, always the management is support. The support. Where will the support come from? We'll start with friends, relative, people around him, siblings, up to communities, LGBT community, okay? So LGBT community. So it's a community where you can contact them and they can support you. So that's number one, management, support. And the support to start with people, friends, relatives, and end up by community. Number two, CBT, talking therapy to relieve the stress, to relieve the social anxiety. So CBT, talking therapy. Three is referral. Referral where? Right away to gender identity clinic. Without any delay. Okay? Now, that's one scenario. That's one case of managing the psychosocial impact. However, this patient or this person may need to be on medication, but this is a further step. They may need to be on estrogen, but that will be done by the gender identity clinic. Estrogen, if this male wants to be a female, or testosterone if it's a female wants to be a male. So medication. So my management here will be support, family, friends, siblings, CBT, community, and medications. Okay? That's one scenario. There is another scenario which will only differ in management. If the patient is coming to you and said to you, I'm already in the process of transgender. So transgender, okay? I'm already in the process of transgender and I'm using online medications. Advice, that's management. Another case, if someone is coming, transgender on medication, online medication, advice to stop the online medication and always offer them to go to the gender identity clinic where they will give them the medications like what? Like estrogen. They can give them estrogen patches, okay? And in this case, if this male will be put on estrogen patches, okay? And if he's using a medication, so always investigations, clotting profile, D-dimer, ECG, bloods, okay? And talk about the side effect of estrogen, like it's increased the blood clot, risk of PE, DVT, and again, support system, start from the family, friends, siblings, and end up by CBT, token therapy, and LGBT, and at the end is the safety netting for suicide and low mood, okay? So now, yes. Now, the next case is, so now we have discussed two cases about the gender. We've discussed two cases. We've discussed a case of someone who's 16 years old, coming worried, stressed about some of the feeling that he has. I said, explore the feeling, what kind of feeling and everything. Reassure him, tell him it's normal, nothing wrong with it, and then ask about the mood, support, and suicide, okay? And impact. I said to you, management is pure counseling. Start with support, people around him, end up by LGBT, CBT, and gender identity clinic. I give you another scenario of a male who is started already on medication online and is coming. So advice, it's another case, that's a new case. Take history from him again, about what's happening with him, support, mood, suicide, everything, and then advise him to stop what he's taking. This is another case. He's already started treatment. The first one, he is confused. That's why we said immediate referral to gender identity clinic. Immediate. Because he's confused, immediate. But the second case is no immediate referral. He's already started medication online. So he knows what's happening. He knows what he needs. He knows that he wants to be a female. He knows. Different case. Stop the medication that you're using online. We're gonna refer you to gender identity clinic. They will give you another medication, like they will start you in estrogen. Estrogen could be tablet, could be patches. They will start you in patches because there are side effects for the tablets, which is everything else. Plus support, family, friends, people around you, CBT. Okay, safety net for suicide. Okay, this case is coming. Is talking about sexual harassment in the workplace. Sexual harassment in the workplace. The cases again. Open the door. It's a female. Looking down, upset, anxious, stressed. Again, it's all about acknowledging. It's all about I can see you're upset. I can see you're looking down. I'm here to help you. Open for me. I'm here to support you. That's it. She opened. When she opened for you, how can I help you? She said one of the colleague is basically doing unethical behavior against with me, is actually doing inappropriate stuff. Always explore, you need to know more. And this is the presenting complaint. Since when? How did it start? Okay, and have you spoken to anybody about it? Have you spoken to the manager or the employer about it? What did he say? And then ask about the mood. Sexual harassment. Sexual harassment. Ask about the mood. And is this harassment verbally or physically? You need to explore verbal or physical. Ask about support. Have you spoken to anybody about it? Start with the employer. Have you spoken to the employer, friends, relative, people around you? Why did not? Okay, and what do you react? What did you do about it? And then ask about the impact. How's it affecting hair, psychology, okay, and psychiatry, pure, okay? Then in this case, the management is number one, incident form, okay? Number one, inform senior. Number two is ask her to inform the employer. Sick note, exactly like the previous case. Sick note, take a sick note, okay, sick leave, and over here support, and support to start from family, friends, everybody, okay? And always for low mood, refer to psychiatrist, CBT, token therapy, okay. Next case. Next case is anorexia nervosa. Anorexia nervosa, all right? Okay. Before we discuss anorexia nervosa, let's discuss about the postnatal mood changes. Postnatal mood changes. Postnatal mood changes. This is talking about a female just to give birth and she's having low mood. Okay, she's having low mood. She's having low mood. All right. Okay. In this case, the patient will have low mood. The patient will have insomnia. She's not having good sleep. Okay. She had traumatic birth. Okay. And in this case, you always ask about the relationship with the baby and how does she feel around the baby and how does she feel toward the baby? Does she have any feelings of harming the baby or not? Very important, okay? Okay. So we have the baby blues, something called baby blues, which is less than 2 weeks. Less than 2 weeks after birth, okay? So management, that's the presenting, that's the findings. So the findings will be a female just to give birth less than 2 weeks ago, and she's having low mood, she's not happy. Okay, that's it. In this case, what you must exclude any suicidal thoughts. You must exclude any suicidal thoughts or any thoughts of harming the baby or harming others. Very important. And again, it's a counseling station. You will ask about the mood, you'll ask about the support, and you will ask about the suicide. Okay, and you'll ask about the impact and the insight. Okay. Okay. What are the red flags? What do you mean, Dr. More red flags? In this case will come as a GP case or phone consultation case. For example, Red flags means things, if it's there, it needs immediate referral. Red flag, because that will affect your management. If the patient is harming herself or have tendency to harm herself or harm the baby, okay, if she's hallucinating, if she's suicidal, if she's self-isolating, immediate referral to the psychiatry. Immediate referral, immediate referral, immediate referral to psychiatry. Okay, however, if the symptoms are mild, she's upset, she's not happy, she's anxious, she's got a low mood, sleeping problem, at this time, if it is mild, the management is different. The management is support system, classes that will help her about the parental skills, CBT over the phone, talking therapy over the phone, support system from people around her, from the partner, from the relative, from friends, and basically safety net for suicide. So be careful, because the postnatal depression, in the history, I need to ask, or I need to have some question that basically for me red flags, which is suicidal thoughts, hallucination, if she's hallucinating. So I will ask about hallucination, I will ask about suicidal thoughts, okay? I will ask about feelings of harming the baby or harming others, very important, feelings of harming the baby or harming others. I will ask about any delusional thoughts, okay? Is she feeling that she needs to be isolating herself? That must be in the history. If it's there, I will manage immediate referral to psychiatry. Immediate. If it's not there, it's going to be a case of what? A case of CBT over the phone as well. A case of support system, people around her, support system from relative, from partner, and I will safety net her for suicide. But if she has any of the red flags, admission right away. Finally, is a case of anorexia nervosa. It is basically 16 years old girl presented to the GB clinic, because her mom and dad are thinking that she has lost weight. That's it. Talk to her, address her concern. Okay, so the case is her mom and dad thought that she has lost weight. Okay, so her mom and dad thought that she has lost weight. Okay, this is anorexia nervosa. So the case said her mom and dad thought or are thinking that she has lost weight. So you will start by the case by, I can see from my note that your mom and dad, because they are thinking that you have lost weight. Yes, doctor. What do you think about it? What do you think about it? So now you are trying to make her open. What do you think about it means, do you think that you have lost weight? What do you think about it? What do you think about it? Which means, do you think that you have lost weight yourself? Yes or no? Then my P1 is weight. So explore weight. How much have you lost? For how long? Okay, is it intentional or not? What do you do to lose weight? So how much? Since how long? Is it intentional? What do you do to lose weight? Okay, so that's the weight. How much? Since how long? What do you do to lose weight? And is it intentional or not? Okay, after I asked about the weight questions, how much, for how long, what do you do to lose weight, is it intentional or not, then I will start asking specific questions. Specific questions means I will ask about, there's one more question here. There is one more question, which is why. Why do you want to lose weight? Okay, why do you want to lose weight? So how much have you lost? Since how long? What do you do to lose weight? Is it intentional or not? Why do you want to lose weight? Okay, and then this is the first part. Then the second part, I will try simply to ask her about her relationship with others and what are people thinking about her. Maybe she's getting bullied. Maybe Maybe she's trying to copy someone. Maybe she's having Victoria Beckham as, for example, role model. Preference in clothes. So I will ask here about bullying, preference in clothes, preference in clothes. Okay? If she's having any role model, okay? Do you look at yourself frequently? Do you look at yourself in the mirror frequently? So some of them they use the mirror frequently to look at themselves. And if she said yes, what do you see? What do you see means, yani, do you like what you see or not? Basically, I'm trying to read her mind because maybe she keeps looking at the mirror and she thinks that she's fat. Okay, I will ask in details about diet, about exercise, about medical conditions, about medications, about amenorrhea or not, in brackets, period. So I've divided this into points now. So again, anorexia nervosa case, it's a female who's coming, 16 years old, and she keeps losing weight. She's happy with herself, her family are not. So she was brought to the GP. So I will say, I can see from my note that you're brought by your family because you are losing weight. Yes, doctor. What do you think about it? They are concerned. What do you think? Second question, weight. The weight. How much have you lost? Since how long? What do you do to lose weight? Is it intentional or not? Why do you want to lose weight? Then I will go to bullet points. Bullying. Have you been forced into losing weight? Are you in a relationship? Do you have a partner? Anybody around you is forcing you to lose weight? I want to exclude bullying. Why? Because if there is bullying, I will advise hair management. 2, preference in clothes. Do you have any preference in clothes? Usually, they need baggy clothes. So, anorexia nervosa patient, they need baggy clothes. Role model. Do you have any role model? Usually, the role model is someone who's skinny. Do you look at yourself often at the mirror? If she said yes, what do you see? Are you happy with what you see? Then I will explore in details. When I say in details, I mean anorexia nervosa patient, they don't eat well. They will say in the morning banana, in the afternoon orange, in the evening whatever. So explore diet in details. What do you eat in terms of diet? How is your diet? What do you have in breakfast, lunch, dinner? In details. Exercise in details. Do you do any form of exercise? What exercise does she do? In details. Usually they exercise 6 times a day. Medical condition. Do you have any medical condition? Why? To exclude any medical reason for weight loss. There is no medical reason, but just any medical condition, like any problem in that gland in your neck, like thyroid, for example. Are you on any medications? Why? You want to know if she's using a medication like slimming tablet or not. Do not mention slimming tablets, but ask generally, are you on any medications? Period. Why don't ask about period? Because mostly patients with anorexia nervosa, they have period problems, they have late period, and in that you will use this point later on to tell her, well, the problem has affected your period already, which if we don't manage it now, you might not be able to conceive in the future, because girls will be scared if you tell them that you're not going to be able to conceive. They will be scared, they will be worried. That's why I need to work on this, okay? So ask about period, okay? Now, the last bullet point is scoff. 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 S is sick. Do you make yourself sick? Do you make yourself sick in order to lose weight? Some patient, they put the finger in order to vomit so they can lose weight. S, sick. C, control. Do you think that you have lost the control over how much you eat? Scoff. S-C-O-F-F. Do you think that you have lost the control over how much you eat? O. O is 1 stone. 1 stone. Do you think that you have lost more than 1 stone in 1 month? So 1 stone. 1 stone. Do you think they have lost more than 1 stone? F. Food. Do you think that food dominates your life? Do you think that food dominates your life? Because do you always think so? F. Do you think that people think that you are fat? Sorry, do you think that you are fat when others think that you are thin? So, S for sick, control, 1 stone, F is for food, F is for fat. This is my history on anorexia nervosa, and that's it. Don't forget to ask about the mood. The mood, very important. Mood. Don't forget to ask about suicide. So mood and suicide. Mood and suicide. Mood and suicide. So I have put it in a bullet point so you know what is the history, the contents of anorexia nervosa cases. How to manage a case of anorexia nervosa. How to manage a case of anorexia nervosa, okay? This case, if it's in a GP clinic, you will refer to psychiatry. But if it's in a psychiatry, you will admit, you will keep in the hospital. Why? Because they don't have insight. So don't forget to ask about insight. So mood, suicide, impact, insight. Impact, insight. What is the insight? Insight means, do you think that you have an issue that needs to be sorted, or do you think that you have a condition that needs to be sorted? So always don't forget to ask about the insight. Insight. So mood, suicide, impact, insight. After this, mood, suicide, impact, insight. Okay? So if the case is in GP, immediate referral to psychiatry department. Okay? If the case is in the psychiatry, admit. How do I know? So in the STEM, in the question, you will see you are an FY2 in the psychiatry or you are an FY2 in the GP clinic. Anyway, so admit. Admit. Why? For supervised weight gain. This patient, we cannot make them gain weight quickly. We cannot make them get the weight quickly. They will have refeeding syndrome. So supervised weight gain. So admit in the psychiatry department for supervised weight gain. Supervised weight gain. Okay, number one. Number two, we'll run some investigations to rule out other causes of weight loss, like what? Full blood count, infection marker, liver function, kidney function, thyroid function. Okay, vitamin levels, we need to do certain investigation. Three, I will manage symptomatic. That's if she's unstable, but she will be stable. So if she's in the psychiatric department, she will be stable medically. So I don't need all of this. So again, admit. So if I'm in the GP clinic and she came to me, okay, I will need to admit, immediate referral to psychiatry department. Number one, immediate referral to psychiatry. What will the psychiatry do? I will tell you now. Number two, I will do some blood. Blood why? Full blood count, blood sugar, liver function, kidney function, supplement, vitamin D, because to make sure that she is medically all right. She's not anemic or anything, okay? However, in these cases, don't worry, she will be medically stable. Because as I said to you, PLAF2 has a purpose. They cannot bring a patient who is medically unstable and they are expecting you to talk about psychiatry and to take psychiatric history. If the patient is medically unstable, they will stabilize the patient medically first, then they will ask you to take psychiatric history. So the station cannot be both, either medicine or psychiatry. So this case is psychiatry. So psychiatry, so refer to psychiatry for immediate admission, and this patient will need to be supervised weight gain. So admit in the psychiatry department for supervised weight gain. Okay, now she will be under MDT, multidisciplinary team that consists of dietitian who will basically make that kind of supervised weight gain so she cannot gain the weight quickly. Number two, a part of the MDT, the multidisciplinary team, psychologist who will talk to her, psychologist and psychiatrist who will talk to her, and they will change her concept. They will try to change her concept about how she thinks in terms of food and how she thinks about her weight and about her look. Okay, so CBT, token therapy. So they will do CBT, token therapy. Why? To change your perception about diet and about its nutritional value and about the food. So they will change your perception. Okay, so safety netting all the time for suicide. Okay, if there is a risk factor, you need to talk about it. Like if there is a partner that needs her to lose weight, if there is a family member, if there is a relative, if there is a friend, you need to talk about this risk factor. Advise her not to listen. Advise her that, Okay, now, what is the provisional diagnosis if you want to tell her? Anorexia nervosa is an eating disorder. eating disorder, where the patient start to lose weight and they keep losing weight until they reach a weight that is basically not healthy. It's unhealthy weight loss. So they reduce their weight until it reaches an unhealthy level, and it affects their body, it affects the function of their organs. And as you see, I told you, ask about the period because you should have amenorrhea. And as you see, your body is already affected with you have already been having a problem in your period, and you might not be able to conceive, so would like to manage you quickly. And then, as I told you, if the case is in GP, immediate referral to psychiatry for admission. So management, if it's a GP case, your management will start with immediate referral to psychiatry department. Why? Because you will need supervised weight gain and MDT. A team consists of dietitian, psychiatrist, psychologist. Okay? A dietitian, why? To help with the food, type of food, to gain supervised weight gain. Psychiatrist, psychologist for CBT. Why? You need to change your perception about what you think about your weight and your food. Safety net, suicide. If the case in psychiatry, you don't need to say referral, say admission right away. All right, guys, thank you very much. This is the end of the psychiatry branch. However, you will need a small video about many mental states, okay? Many mental state that I will use in psychosis. So the psychosis station, I told you, you will start with cognition question, you will do the many mental state, and at 6 minutes you will discuss management. So after this video, you will be expecting a video about many mental state examination. All right, thank you very much.